All right, everybody. Well, thanks for your patience, and once again, good morning. We're going to go ahead and get started here for yet another episode of CareOregon's MEDS Ed, Medication and Health Series. It's an ongoing program we do here through the CareOregon Pharmacy department that takes kind of a deep dive look at different disease states from a multiple variety of perspectives. So you're going to be hearing from a pharmacist today. You're going to be hearing from other different vantage points other than pharmacy. So you're getting a nice, well-rounded perspective on this particular disease state. We tend to host these every other month. We just did COPD in February. Coming up on the horizon, we don't have a firm date for this yet, but it may be in the fall. We're going to be doing a session on severe and persistent mental illness as well. So that's something that a lot of people have been asking for. So we're developing content for that right now. So go ahead and come on in, folks. If you haven't had a chance yet, sign in and you're ready to rock. As we talk about heart failure here today. This is a rundown of our agenda, what we're going to be talking about, the different types of heart failure and self-care. This morning, we're going to be doing a deep medication review with one of our pharmacists. We'll take a little break, probably around 9:30. And then we'll talk about how the disease can progress, what that means, and segue into advanced illness and palliative care. These are what we've identified as the key learning objectives for our content this morning, focusing in there on the two types of heart failure, palliative care goals, drug classes. And here's kind of an overview of where we're at in terms of heart failure. The poets like to tell us that the heart is the center of our being in some ways. We kind of define it symbolically as really who we are. It's the vessel of our spirit, if you will, but it's also a very complex mechanical and hydraulic engine that powers us and keeps us going on every level you can think about. So the idea that the heart is the focus of our lives in more ways than one is definitely something that you'll see driving some of this content here today, and bears thinking about when you think about how many folks nationally it affects every year. 1 million people each year are hospitalized due to this. We're spending $12 billion a year on 30-day readmissions alone. You're going to find that at CareOregon this year, we're spending a lot of focus on hospital admissions. We're really trying to look at what some of the causes are for that. What can we do, not just as a pharmacy department, but as a healthcare provider, to try and reduce that? How do we minimize the number of admissions that go on for folks? Certainly heart failure, COPD, diabetes, conditions like that are at the top of what's driving those hospital admissions. So you're going to see a lot of communications from us, a lot of efforts, a lot of member education materials aimed this year towards trying to reduce those admissions, and heart failure is certainly going to be a large part of that. It's certainly part of our CCO metrics. It's definitely something we get looked at all the time on there. Lower hospitalizations for heart failure is certainly better. Because as you see, when we go through here, there's a real tie to mortality and admissions, because the more often somebody is hospitalized, going back in again, second time, third time for heart failure, you see a pretty direct tie to how that relates to that individual's mortality. So if we can keep them out of the hospital, ideally, so they're not having to go in that third, fourth time, maybe we're helping to do something positive on the mortality score. So this is how we're dividing the content up in here today. We'll kind of go through these first 3 areas before we move into medication management. And boy, we have a treat for you this morning. I don't know if you guys have been lucky enough to hear Jayne Mitchell present before, but she's from the OHSU Heart Failure Program, and she's pretty phenomenal. And I think we're very, very lucky to have her here to guide us through most of the content here today. So let's not waste any more time with me talking, and let's bring up Jayne. Please give Jayne a warm welcome this morning.
So my name's Jayne, and I'm a nurse practitioner at OHSU. I'm going to talk to you about a subject that I'm quite passionate about. I've been doing heart failure, I can't tell you how long. I don't want to tell you how long. So for a while. And the thing that I love about heart failure patients is that they teach you so much. You're never going to get bored. Just when you think you've fixed them, something else happens. You're constantly learning. And also, we have a case presentation, and you will see that this lady really tested our system. And if you can build a system that can accommodate your most complex patient, sort of a fail-safe system, you've developed a really good process to take care of these patients. So I'm going to start with Mrs. J, and she is, the first time I see her, a 49-year-old female living with her family, and she comes into the clinic short of breath. So I look in her history. She was diagnosed with hypertension when she's 14. So was she treated when she was 14? Not really. They just noted it. And also remember that when she was 14, what were our criteria for hypertension? I mean, we had all kinds of weird recipes. Your age plus your plus 100. Like, there were all kinds of things before the SHEP trial that we actually figured out, oh, you know what, we should probably treat this hypertension. But at 14, nobody really knew what to do other than just note it. Her blood pressure had been ranging from 160 to 180 for years and years. 4 children and pregnancies, the first 3 with no problems. However, on the 4th pregnancy, she felt horrible. She was short of breath, tired. She had pedal edema. She had all kinds of issues and really not well managed at that time. In 1994, she had more shortness of breath. She couldn't keep up at her home, and she actually went to the emergency room. So this is a lady who's been toughing it out for years on her own. And now she's finally presenting. And when she presents, she's pretty progressed in her heart failure. By this point, we've got years against us that we haven't really done anything for her. So she's noted to have cardiomegaly on her chest x-ray, big heart, and pulmonary edema, and her EF. When we look at her echocardiogram, do you guys look at echocardiogram results? So you always want to look at the echo and see what their ejection fraction is, and that's the amount of fluid that their heart is pumping out with every beat. So her ejection fraction is 20, which is pretty low. So I'm going to back up, and we're going to talk about what is heart failure. Well, heart failure is just a word that we've assigned to this complex syndrome. In order to be diagnosed with heart failure, you have to have symptoms, and you have to have functional changes on your echocardiogram. So those are the 2 things, but it is a syndrome. It's also a very poor way of saying that somebody's heart is not pumping efficiently. So if I go into you and I say, hey, you have heart failure, you're not going to hear anything else I say. It's such a horrible word. And I belong to the Heart Failure Society of America. It's a weird club. But so the thing is, for years we used to have this debate of why do we have to call it this? This is so like demoralizing to patients. But here's the deal. Research has been done under heart failure. It's like changing the name diabetes. So finally, people gave up, and we just call it heart failure. So that's the long and the short of it. So what are the causes? Used to be coronary artery disease was the #1. However, now the #1 cause of heart failure is hypertension. And that is, you're going to see that more and more prevalent with the baby boomers getting older. So when you guys see these patients in clinic, just your regular patient who has hypertension, it's nothing to just look the other way on. You have to treat it. And we have to become very, very aggressive with this hypertension. Valvular disease, I don't know if you guys are seeing these patients that come through with TAVRs now or MitraClips, but a lot of our older patients who couldn't have surgery before now are developing heart failure, and we're doing a percutaneous valve, so they just take them to cath lab and put in a new valve then. And so these are really sick patients. So we're seeing that group come out again too. We have our genetic heart failure patients, the hypertrophics, the congenital, and these these are patients that were born with either tetralogy or Fontan, and they had like a single ventricle, and they had procedures. This is probably the toughest group of people to take care of, in my experience, because these are kids that have been told since day one, and parents, you're going to die, you're going to die, you're going to die, and now they're 30, and we say you should never have kids, and guess what? They get pregnant, and so then they have the kid, and then they're back into heart failure again. These are people that are so resilient that it's really hard for us to understand what they've been through. It's really hard to sort of meet the patient with their goals, because again, they've been told they're going to die forever. And guess what? They haven't died. So this is just a different substrate of patients. We have the peripartum. I see a lot of patients up on 13C and 14C after delivery that now have heart failure. Typically, that is a heart failure. They have to be treated forever, but we really have to be aggressive with that patient at the very beginning and get them on the right medications, because heart failure gets worse because of neurohormonal response. So if you don't block that neurohormonal response, the patient will not get better. And we have our infiltrative. You're going to see more and more of the amyloid. So what does that mean? That means that in my heart muscle itself, instead of having regular tissue that works the way it's supposed to, you have it lined with something. So with hemochromatosis, instead of regular tissue in my heart muscle, it's actually lined with iron. Well, guess what? Iron doesn't expand and contract so well. And then the other thing is with amyloid, instead of having just the normal tissue, what I have is protein embedded. So these folks are really hard to take care of because they have no wiggle room. Their weight can go up or down 2 pounds, and they can be dramatically symptomatic. So you know how we say up or down 2 pounds or 3 pounds in one day. These folks will tell you if they're up 1 pound, they can feel it. So this is a very different type of heart failure, and we treat it a little differently. And then you can have infections, inflammatory process, metabolic disorders, toxins. All of our patients who are on chemotherapy get an echocardiogram, and then we repeat the echocardiogram after the chemotherapy course to make sure that we're not affecting their heart, because it can be cardiotoxic. If it is, we change the chemotherapy. That patient will not receive that chemo again, but we do also block the neurohormonal response. So we want to make sure that patient's on an ACE inhibitor and a beta blocker and spironolactone if they need it. So for those patients, you want to be very aggressive. And then the arrhythmias. So how many of you have seen the little old lady with AFib and RVR, right? So they get into this rapid heart rate and they start filling up with fluid. So there's those patients, but now we also have the group of patients who come in with ventricular arrhythmias. And Tommy Dooland up at OHSU just recently had a paper that was put out that talked about if you have more than 20% of your heartbeats are PVCs, it can make you go into heart failure. What do we do for those folks? We bring them into the cath lab, we ablate that PVC, we get rid of that one focus that they have, and then they're okay. We block the neurohormonal response. You're gonna hear me say that a lot today. So there's really 3 types, but I only put 2 types because the one in the middle we'll talk about, it's like the gray zone. We have heart failure with reduced. So that means if I looked at the echo, I would see that the EF would be less than 40%. And then we have heart failure with preserved. And preserved means if I looked at the echo, the ejection fraction would be greater than 50%. So you notice I left out 10 full percentage points. So that is actually called heart failure with either mildly reduced ejection fraction or heart failure with moderately reduced. So the thing about that middle land is you treat it according to the patient. So if that patient had an EF of 20 and they're coming up now to 45, I'm still blocking the neurohormonal response. If that patient was a 50 and they're going down to 45, I'm probably going to treat their comorbidities, but we'll talk about that in just a minute. That'll mean a little bit more. The other thing, remember systolic and diastolic? You guys have heard that terminology as it relates to heart failure. The only reason that we use that terminology is because that's what our government uses for coding. So you will see in a patient's chart, heart failure with systolic dysfunction. Nobody really cares about the systolic thing. The most important thing is it's heart failure reduced ejection fraction. So you'll probably see both things listed. So really systolic is heart failure reduced and diastolic is heart failure preserved. But we only do that for billing. So again, how you figure out what kind of ejection fraction the patient has or what kind of heart failure the patient has, you look at the echo. The echo is always going to be, even though there's not one test that can say that the patient has heart failure for sure, the echo is probably the one that you would want to go to first. So remember, if my heart's beating, if I have 100% ejection fraction every time my ventricle closed and then opened back up, what would happen to my brain? All the blood would get sucked out of my brain and I'd pass out. So 100's not a good number. So you have to tell these patients when you're telling them what their EF is, 100 is not normal. Normal is 50 to 60% of the contents that get pumped out each time. So, and sometimes you'll see little hints in the echo, like it'll say systolic dysfunction or diastolic dysfunction. As a rule of thumb, most of your diabetics will, whether they have heart failure reduced or preserved, will also have diastolic dysfunction from their diabetes. So you'll see that even if their EF is 20 and they're diabetic, you'll see something about the diastolic dysfunction. And then look at the valves. If the valves are working all okay, then you don't really have to think about it. If you have like tricuspid regurg, so that tricuspid valve is wide open, then you know when you look at that patient, their neck veins are going to be up. So start thinking about like which valve is that and how does that affect my patient. So here's the deal about heart failure. The prevalence of heart failure with preserved ejection fraction is increasing. And I know that a couple of you have had my classes before, and I know, so you know this answer, so you can't say anything. So here you have, this is heart failure with reduced ejection fraction, and you can see the line goes down as projected by 2020 to be about 30% the prevalence. And then here, heart failure preserved is going up. And then again, here's the heart failure. We don't really know what to call it, and we don't really deal with that one. That's the least of our worries. So why do you think that heart failure with reduced ejection fraction, the prevalence is decreasing?
Obesity?
Better management?
Better management for sure. So obesity, how so?
Oh, no, I was thinking.
The other one?
Yeah.
Okay, you're right about the other one. So the thing is, it used to be patients would stay home, they'd have chest pain, they'd stay home for 3 days, they'd come into the cath lab, we'd inject their coronary arteries, and there would be nothing. Those patients had horrible heart failure with reduced ejection fraction because they really had nothing, they had no tissue left, so it was too late. So we developed STEMI protocols. So now that patient has chest pain, their neighbor says, you need to be seen. You need to go in right now. I'm driving you in, or we're calling 911. Those patients are now seen in the cath lab within, 90 minutes, and we revascularize them, and they're fine. The other thing is, you're right, the research. We know, we zeroed in on this group when it happened, and we know that this is all about the neurohormonal response. So you figure out why the patient has the heart failure, you fix that or deal with it, and then you block the neurohormonal response, namely an ACE inhibitor, beta blocker, and spironolactone. Yes?
Are you actually going to talk about the neurohormonal?
Yes, I am.
Is that like ADHD or something?
Pardon me? So I'll talk into that in just a few minutes. So it's a good question, good segue. And the other thing, why is the preserved ejection fraction getting higher? Baby boomers, age, hypertension, diabetes, obesity. So these are the reasons. And so you can expect, and let me tell you, if I look at a heart failure reduced patient, I'm talking 4 meds. These patients generally are pretty organized, just as a rule. And then I go to a HFpEF patient, with the exception of the patient we're highlighting today. Then I go to the HFpEF patient, and it's all messy. Everything's messy. Their diabetes is out of control. They're not wearing their BiPAP, blah, blah, blah. So those patients are really tough. And those are the patients, I believe, that can really benefit from good nursing care and good paramedic care. You guys are in there with the 65 meds that you see, and you're like, oh my God, like what's happening? So here's 2 different scenarios. You have the patient on the your left, who is a 60-year-old man with a long history of heart failure. He comes into the emergency room. His pressure's 85/40. He's mentating okay. And he's really short of breath and not feeling well. And then you have the 80-year-old lady who just went out and had Chinese dinner with her daughter, and she comes in and she's like gasping for breath. Her pressure's 185/120. So who is gonna die quicker than the next one? Like, what do you think? Who's the 60-year-old? What do you guys think? We'll talk about that in a second. So when I look at this patient, when I listen to their lungs, I may not hear one crackle. So if I listen to somebody's lungs and they don't have crackles, it means nothing. It means I don't hear any crackles. That's what it means. So the reason I wouldn't hear crackles is because this gentleman has been accumulating fluid for a while. And what will happen eventually is they'll get left pleural effusions, or they'll get the fluid in their belly or in their legs, but they accommodate it a little bit better because it's slower, versus this lady who all of a sudden had this high blood pressure response to the sodium, and everything sort of shuts down. And do you think I can hear her crackles? Oh yeah, I probably don't even have to get my stethoscope out, right? Like this is a lady that's sitting up, like gasping for breath when she comes to the ER. What is the answer for both of them if they're fluid long? There's one simple drug. If you can remember nothing about heart failure, remember Lasix. So sort of like hydrocortisone cream for skin problems. You always want to try it. So the thing is, if I look at this echocardiogram on this gentleman, look how big that ventricle is, and I look at his heart, it's like a basketball, right? So it's changed its shape. And so this might accommodate 200 cc's where normal is like 50. And then hers, look at her echo. Like, do you see this little part is where the fluid is? So if his EF is 20 and her EF is 70, it doesn't really matter, right? Like hers is 70% of 5 cc's, not much. His is 20% of 200 cc's, not much. So it doesn't matter what kind they have. Of course, you want to sort of know what kind they have because it's going to help you treat them. Basic first line, Lasix. Does that make sense to everybody? And the reason, why do we think the reason that her heart is so thick? What condition did she have for years that caused that? Hypertension. That's why you want to treat hypertension. So HFrEF, HFpEF. Guess what? They both have the same mortality rate. If you were diagnosed with heart failure, 5 years down the road, 50% of those patients are dead. If you've had one hospitalization, as Paul showed you a few minutes ago, then it's like 35% in 5 years will be dead. So this is like a very, this is a horrible disease, and regardless of what kind you have, it is also causes death. And this is the same picture that you saw a little while ago. Every time that patient goes into the hospital, their mortality rates go up. If you see a patient in your clinic and they've been hospitalized 4 times this year for heart failure, their mortality rate is about 60%. Do I want an advanced directive on that patient? Absolutely. Do I want to talk about goals of care with that patient? Absolutely. And it doesn't mean anything bad about the hospital, by the way. It's just a marker that they are really sick. So then when you look at your physical exam, what are you going to see? These patients have a dry, hacky cough that occurs more often when they lay down. This is not to be confused with an ACE cough. An ACE cough is 24/7. So they cough constantly all the time. You can't, like you can hear it down the hall. When your patient comes in with an ACE cough, have you guys heard that? So you know, and you know you got to deal with it. And if it's a little old lady and she's got the cough, she's going to hate your guts because she's incontinent too. So you got to deal with this stuff because otherwise they're not going to take their meds. Does it mean that the cough the cough won't hurt them? But here's the deal: every time I go up on the dose, it's going to make the patient cough more. So that's not really good. If I'm trying to get to a target dose, I'm going to switch the drug, and we're going to talk about that a little later on. So, but the heart failure cough happens when they lay down. So when they're laying down, what happens is all the fluid from the legs and the belly will massively come up to the pulmonary vasculature, and the patient will basically get a little like pulmonary edema, and that's what makes them cough. It also makes them sit straight up in the middle of the night and feel like they can't breathe. And by the way, that's really indicative of pulmonary edema and has to be dealt with that day. If you have a patient that calls and says they keep waking up in the middle of the night and they can't breathe and they need something for anxiety, my answer is, oh no, I don't think you need something for anxiety. Let's just make sure it's not your heart failure. So that patient needs to be seen. They're tired, they're short of breath. Shortness of breath with exertion, probably the most common symptom. I always ask the patient, how many stairs do you have in your home? And then I use that as the marker, how many can you go up before you have to stop? But that's probably your best bet as far as figuring out how these folks are doing. They sometimes will get swelling in their abdomen, and when you get fluid in your liver and your belly, it makes you lose your appetite, and it makes you feel like crap. So you have to be, if you hear those symptoms, those are heart failure symptoms. And then also, sometimes we see pleural effusions or swelling in the ankles or legs. Here's the deal. You have a patient who only gets short of breath with exertion. You don't have to spend any other time teaching them about the other heart failure symptoms. Zone into that. Teach that patient, this is your red flag. So you want to keep it simple. If the patient's problem is that dry, hacky cough that they get when they lay down at night, then you say, hey, that's your heart failure symptom. So you have to watch out for that, because patients will disassociate those symptoms quicker than anything. You mean my leg swelling has something to do with my heart? I've heard that so many times. And so you have to just make sure from a nursing standpoint that you teach that patient that symptom. You don't have to give them the list of 10. Just figure out what their symptoms are and hone in on it. Does that make sense to everybody? Okay. Shortness of breath, dyspnea on exertion, orthopnea, fancy way of saying stacking pillows on your bed. Patients think I'm obsessed with their pillows, but I assure them it's just a marker of me to figure out how much fluid you have, because if I have extra fluid, I will start adding pillows. And the other thing is, even though you ask how many pillows are under your head at night when you sleep, they will tell you what's on their bed, and then you'll find out 2 months later they've been sleeping in a chair for 6 months. So I always say, where do you sleep? And if it's a bed, is it flat? How many pillows? But I always document that, because that's really valuable information. The abdominal bloating and peripheral edema. So, okay, I apologize for this slide, a little busy. The only reason that I have this slide up is to show you that heart failure is a continuing, a process. We tried to address the hypertension and diabetes earlier, sort of like metabolic syndrome for diabetes. And this is from the American Heart Association. So we've staged patients, stage A, B, C, and D. D means you're so sick, you're not going to leave the hospital unless you have inotropes, a VAD, a transplant, or hospice, or palliative care. A means you don't have heart failure, but you have something that can cause heart failure. Okay, so if I look at the echo, echo's normal, but maybe I have hypertension, I have stage A. I'm at risk for heart failure. If I had chemotherapy and my EF is less, I have stage B. So I have a structural change, but maybe no symptoms. That's stage B. So how I'm going to treat stage B with structural symptoms is I'm blocking the neurohormonal response. And then we get into C, which is what you're going to see most of the time. You've got your HFpEF and HFrEF, and the goals for therapy are there. So basically, always decongesting the patient. If it's HFpEF, we deal with that by treating their comorbidities, and that is not an easy task. You know, you got to wear your BiPAP, you got to take care of your diabetes, you got to get your hypertension under control. Again, these folks are a little messy. And then HFrEF, of course, blocking the neurohormonal response.
Can we get that slide? Because it's not readable in this.
Oh, sure. Yeah, you can.
There's a handout too, like a larger version of it that should be in the front pocket.
Of course, Paul took care of that. So then HFrEF and HFpEF, in summary, heart failure with reduced is a low EF. You know you've got a decreased stroke volume, you've got backward failure, forward failure, you've got basically a basketball heart that's not pumping well. Heart failure with preserved, you have the clinical signs and symptoms of heart failure. If I look at the echo, it's going to be greater than 50%. And these patients, the prevalence is increasing. It's their comorbidities that I treat. And again, that is not an easy task. It's the hypertension, the sleep apnea, the diabetes, the obesity, all of those things. And it's very difficult to care for. So I think of, as far as the goals, you want to improve quality of life and prevent hospitalization and mortality, right? So, and of course, I'm a big advocate of yearly checking in with that patient and figuring out what their goals of care are, because we want to make sure that our goals are the same, because if they're not, then we're both working in two different ways. It just doesn't work. Everybody has to work way too hard. So for HFrEF, the guideline-directed medical therapy includes your diuretics, your ACE or your ARB, and now there's an ARNI, which we're going to talk about later on. Not very common, maybe 1 in 100 patients will be on that newer drug. There's beta blockers that are approved for heart failure. Okay, atenolol does not work for heart failure. We know it's got to be carvedilol, bisoprolol, or metoprolol succinate. So there's only certain ones. And in some patients, if we take them to the, we do a right heart cath and we see that they're sort of clamped down and they need afterload reduction, we'll put them on hydralazine and nitrates. Also, the other group of people that need hydralazine and nitrates are your African Americans who have a low EF. And that means they're on an ACE, beta blocker, spironolactone, and now hydralazine and isosorbide, which, believe it or not, even though what year is this, 2017, is a 3 times a day dose. Absolutely horrendous. I'm like, what year is this? And why can't they figure that out? So the reason that you want your African Americans on this is because it reduces their mortality by about 43% in addition to their other drugs. So that really, you really have to do that for your patients. Digoxin, hate to say it, feel better and die drug. Okay, it's not going to make you live longer with heart failure. There is a group of people with heart failure who actually feel a little better. I am not going to add this drug until I'm really grasping at straws for my patient, because it's great with AFib, so don't get me wrong, if your patient has AFib, I get it. I did just fine. But for heart failure treatment, it is really not our front line of treatment. If I have a patient, I've got them on the ACE, beta blocker, and spironolactone, and they come back to me and they're like, Jayne, I still have a lot of fatigue. There was a small group of patients in the trial that they did with 10,000 patients, and it was an NIH trial. And those patients, a little subset, felt a little better. Here's the problem with DIG, is it interacts with everything, as you know, and your patients start changing the color on their TVs, you know they're getting toxic. The other thing about that is the target dose is 0.125, you want 0.125, not the 0.250 that you would use for AFib. And the level, instead of being 2, should be 1 or a little bit less than 1, so that the rules are a little different for heart failure. And then after we up-titrate these meds, we wait about 3 to 6 months. We repeat the echo. If we've not made progress by blocking the neurohormonal response, we are going to think about, does this patient need sudden death prevention? Does this patient need one of those, the pacemakers that paces both sides of your heart, so it fixes the timing, if you would, of your heart? And very effective for patients with big left bundle branch blocks that have heart failure. So do they need that, or do we need to do something else? Like, is there something going on with their valves? And then for HFpEF, of course, got to tell you, you got to treat all those comorbidities, and that's what you focus on: decongestion and comorbidity. So again, that's the hard one, I think. And this is the new, the update of the goals, because here you've got your ARNI listed with the new medication that just came out 2016 on the guidelines. So really we're just dealing with C and D. The other thing is to classify your patients. We like to have them staged and classified. So by staging, that means I'm going to say, when I see a patient, this patient is stage C, or this patient is stage D. And it gives you an idea of what I think their longevity is. So if I say C, that means they've got heart failure symptoms and structural disease. D means big bad things happen, and we have to have a lot of discussions, and we need to really regroup and deal with this, like, what does this patient want? So most of your patients, if you look at New York Heart Functional Class, you have 1, which is no limitations, and 4, which is short of breath. There's been a lot of debate over the value of New York Heart Class Association, that classification system. I would tell you that it's probably the best we have. The other answer to that is a 6-minute walk test. Has anybody done that? Okay, I'm really lazy. I hate those tests. I absolutely hate them. They worry me to death. The patient, is short of breath after 50 meters. So you have 6 minutes and you make the patient walk and you count how many meters. So here's the deal. Guess what? because they have heart failure, they can't get very far. So you run behind them with the chair and like you're like worried for 6 minutes. So I'm like, okay, forget that, I'm not doing it. So I think it's great for some of the studies and some of the devices we put in, we have to do it. So we've got that measurement. I'm just too lazy. I just always find out like how many steps do you have and what are your symptoms. So I feel like if you rate the patient on the same metrics every time, you'll be more successful. We also know that if you had to pick one thing that you looked at as far as mortality, if you have a patient that's a classification 4 and you can't budge them, their mortality rate is 60% in the next year. So there have been a lot of studies that show that. So even though it's sort of a crude marker, it's better than nothing. Most of the patients in the hospital, C and D, 3 and 4. My goal in the hospital is to move them a New York Heart functional class backwards. So if you come in 4, short of breath at rest, I want to move you to a 3. If you come in as a 3, I want to move you to a 2. And then you have people like me that like to call sometimes 3s or 3Bs, which means they're 4s sometimes, but not all the time. So, so you're always trying to push that back as far as your goal of care. Now here on your stages, when you go from A to B or from B to C, you can't go back. So this only goes one direction. The only way I can get from a D to an A is how? There's only one answer. Transplant, exactly. You guys are catching on. So back to Mrs. J. What is likely to be the etiology of her heart failure?
Hypertension.
Yay, okay. And what type of heart failure does she have? Remember her EF is 20%, so what does that make her? HFrEF, yeah, heart failure, reduced ejection fraction. What stage of heart failure is she in? I can't remember if this is C. Reasonable. And then if she comes to the office short of breath at rest, before you send her to the emergency room, what New York Heart class is she? So she's short of breath at rest. What number is that? 4, exactly. So, oh good, I didn't know if I could do that or not. It was one at a time. I didn't want to spoil the whole thing. So there you have it. So my goal is I'm not going to move her from a stage C to a B, right? That doesn't happen. My goal is to change this. That's my primary goal when she's in the hospital. And also to reduce mortality. So those are the things I'm after. And guess what I'm going to do? I'm going to optimize her medications. That's how I'm going to do that. Here's the thing about the disease trajectory. This is such a bummer talk. Okay, so anyways, when somebody's first diagnosed, the reason they're diagnosed is because their physical function has decreased. So here I have a patient whose physical function has decreased. They come in, I do the test, I say, hey, you've got heart failure. I get them on diuretics, I fix their medicines, I treat them, their function gets better, correct? So then here's the deal. They go for a while pretty well. Like this is where we teach them about weights. We teach them about taking their medications and going to their appointments. So there's a huge teaching window right here, if you would. That's a really good spot to focus on these folks. So then they do well for a long time. And then what starts happening is they start having these little blips. So maybe they go out and they eat or they miss a med. And the next thing you know, they're in the hospital. So they go to the hospital, we get them optimized again, and maybe they come out and their function is not quite as good. So you guys know that like this happens a lot. Most of the patients you're going to see probably with heart failure are going to live around here is my guess. Although you will see some of the very beginning ones. This right here is a teaching moment, by the way. This is the problem between 2 and 3. The patient learns how to cheat. So what happens is you say to me, like, I'm really good. Oh my God, I've got heart failure. I weigh myself every day. I take my meds. Then I go to this family reunion because it's like a year out and I'm really, really good. And I eat salt. And guess what? Nothing happens. I'm totally fine. And then I think, dang it, Jayne Mitchell lied to me. So then what happens is I miss a couple meds. And I'm like, oh, these people are total losers. They're lying to me. So I start getting a little loose with my rules. What will happen is the patient eventually, when they start getting sicker, because the disease will progress, they start getting sicker and they'll start having these bumps. This is a teaching moment. So I will sit with patients, I'll draw them this picture and I'll go, where are you? I explain it to them, where are you? And they'll go, well, I want to be here, but I think you're going to tell me I'm over here. And it's just a really good visual for those patients to know where they are. Does that make sense to everybody? Okay. Stage C is in this area. Stage D is in that area. Now the other reason that would take me from this back to 2 is a VAD, right? If I put a VAD in somebody, how many of you guys have a VAD patient? So that patient still has heart failure, and the only thing that will take them back to 2, they're still always going to have heart failure, so they still need to do their weights and all of that. It's just that they have an assist. So goals of therapy: control symptoms, improve quality of life, and prevent rehospitalization and reduce mortality. So how are the goals of therapy addressed? Remember, we're going to do, for HFrEF, it's all about that neurohormonal blocking. That's what we need to do. The patient should always be euvolemic. If you have a patient that's up 10 or 20 pounds, leaving them up 10 or 20 pounds does not help them. You have to get these patients decongested. So if they increase the diuretic during the office visit, you want to follow up with that patient. Did that weight go down? If it went down 3 pounds, but it's just staying there, you still need to be more aggressive. You need to get all of the fluid off of that patient, because as they're more fluid, if I have all this extra fluid, what happens is when my heart is pumping forward, my cardiac output is reduced, right? Just like a kitchen drain. If I've got a really tight drain, so more fluid on this side, it backs up. I don't want it to back up. I want my kidneys to get a good amount of blood, and I want that fluid out of there. So you have to be very aggressive about diuretics. And that is something I think we're learning more and more. We're putting these CardioMEMS, which is a sensor in the pulmonary artery, and we're learning that our patients are way, way, way too much fluid. So even before they have symptoms, they have a lot of extra fluid. So I would err on the side of pushing the diuretics too much. So salt makes fluid come, right? So here's the deal. When you have this response, what happens is your kidneys notice that your cardiac output isn't as much. So your kidneys say, gosh, I'm going to help Jayne out. She needs some fluid. So what are my kidneys going to do? They're going to hold on to salt, because wherever salt is, it pulls in fluid. So I'm not going to pee out salt anymore. And they're also going to send the messages to my brain that I'm thirsty. So I'm going to drink, 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 and eat more salt. And guess what happens to my fluid? It increases. So it's a really vicious circle that occurs. And so the basic part for patient education is they got to adhere to these low salt diets. If you have a patient who is definitely like they're on 160 of furosemide or 200 of torsemide on the higher doses, and they're barely keeping even, I can tell you that patient needs some education about their salt. They're probably eating salt. They're either so progressed in their heart failure that it doesn't matter, or they're a stage C and they're eating salt. Because how is it that we take them into the hospital, we control these variables, we give them 40 of IV Lasix in their peeing buckets, because we're not combating that salt that they're taking in. So you have to be very careful with that. So this is, we talked about woes a couple of years ago. Weights, you got to observe the patient, see if they're symptomatic. Educate, educate, educate. It never gets, you should always educate the patient. You should always assess what's going on. What happened? Your weight's up 20 pounds. What happened between last visit and this visit? Oh, you stopped your medicines. So I did a home visit the other day, and the lady had like a huge bag, shopping bag, of all the naturopathic, like she had hawthorn berry, she had everything. I was like, oh my God. And then I looked at her metoprolol, and her EF is 20. Metoprolol, full bottle. Losartan, I don't take it because I have a cough. Somebody told me that makes me cough. I was like, oh my God. And then the furosemide, she wasn't taking that. And I was like, okay, so here's the problem. These are the medicines that will make you live longer and will help you. and you're taking these medicines. I mean, that's a lot of money these patients are, really spending on some of this stuff. I was like, I don't know what this, when you take all of this together, I don't know what recipe you make inside of yourself. I don't know what that does. So it's all about education. As far as the compensatory mechanisms, basically I'm talking about a couple things. The sympathetic nervous system. What happens is my adrenal glands sense that I don't have a good cardiac output, that I'm not getting enough fluid. They send norepinephrine and epinephrine to my heart. And the reason that they do that is they're trying to tell my heart it's in trouble. So these cells in my heart will talk to each other. And so one cell will say you're in trouble, and the next one say you're in trouble. So eventually they all convince themselves that you're in trouble, and your heart will actually change shapes. And that's how people who have had a heart attack in the past that have like an area of dead tissue, when they get this neurohormonal activation happening, you can look at their echo if they're not on a beta blocker, and their EF will go down and all of their tissues will become effective, even though it was just a small portion to start with. So that's a pretty simplistic way to think of it, but that's how I think of it. The other thing is the renin, angiotensin, aldosterone system. And I think that when we talk about pharmacy stuff, we'll go into that a little bit more in detail. But just suffice it to know, salt and water retention. And it's all the activation. It's all because your kidneys are trying to help, and your kidneys do not help you in heart failure. Okay. So this is a picture of a gentleman who came in with an EF of 41%, sat on his heart attack for a while. This was back in the day, 2000. This is when it was happening. This is the SAFE trial. So what happens is, he gets to the cath lab when we shoot his coronary artery, and guess what? There's not a lot happening there because he's already occluded a whole vessel. So we're like, okay, 41%. He's got a bigger ventricle, but he's doing okay. This guy untreated, this is before we knew to put people on ACE inhibitors and beta blockers. Guess what? All by himself, he goes from 40 to 23. So why did that happen? So first people were like, maybe he infarcted again. Like maybe he had more coronary artery disease, and they look at his vessels, and nope, that's not it. So it's something else, and what it is the neurohormonal response. That's what you're trying to block. So let's talk a little bit about the renal function, and I've talked to you about, like, if you've got this chronic hypoperfusion, you've got reduced oxygen. What happens is, remember, your kidneys make everything, because your kidneys think you're low volume. Your kidneys don't say low pump, bad pump. Your kidneys say not enough fluid. So they clamp down everything, and that makes it, even harder for your heart to pump forward. And then they start sending all this stuff. They start sending all these hormones. And this is, again, what makes heart failure so bad. So they're going to make you retain salt and fluid, and your patient is, guess what? Guzzling water, and guess what? Eating salt. So it makes it even worse. And here's the key thing. If you think about worsening renal function, the actual definition is a change in your creatinine greater than 0.3. You guys see that like every day, right? 0.3. In the hospital, I see it like in 12 hours. It's a marker. Your patient that you are looking at that has heart failure that changes that creatinine that quick is, where do you think they are on the scale of heart failure? Are they progressed? They're very progressed. So this renin, angiotensin, aldosterone system is these kidneys have been hurting for a while. So when you see a change in creatinine like that, you know that that patient is really sick. So you have to jump on that. If I've got a patient whose creatinine went up 0.3 or greater than 25% over baseline, that means really I need intensive care for that patient. Does that make sense to everybody? It doesn't seem like much when you look at the paperwork, but it is. And then the sympathetic, it's your fight or flight, elevates your heart rate. If you see a patient that has heart failure and their heart rate's 110, you need to pay attention to that patient because they're really in trouble. That patient needs some work. And also remember, what happens eventually with your cells talking to each other, you're in trouble, is they start dying off because of it. So your cells will convince themselves that they're in so much trouble, they just start dying. And that's never a good thing. Cardiorenal syndrome, you know, it used to be, I can remember years ago a patient would come into the ER and we'd give them like 20 Lasix because, and they'd pee out like buckets. And I remember providers saying at that time, this patient must not be adherent. They must not be taking their diuretic. So here's the deal, what we discovered later on, and sometimes that was true, but what we discovered later on was some of these patients who get fluid in their belly, so they get this gut edema. And so when I take oral Lasix or furosemide, I get about 10% of that. So it's only bioavailable 10 to 20%. So not much. So I could be taking 200, right? And it's not very effective because I have all this bowel edema. If I switch that patient to torsemide or bumetidine, that bioavailability is about 80%. So my patient gets a lot more. So the first thing I do when they come in, if they've got extra fluid and I've got them like on 160 of Lasix, it's clearly not working, and usually diuretic we like to give in 2 times a day doses for heart failure, by the way. It just works a little bit more efficiently. I'm going to switch them to torsemide. It's the first thing I'm going to do. Because I know, guess what, this therapy doesn't work for this patient. So this is a patient that probably has some gut edema, so I'm going to switch them. The other part of that is if you see a patient that is on torsemide, what does that tell you about the patient? Where do you think they are as far as their disease? They've progressed, right? So this is a patient that's more resistant to their diuretic. So it's just sort of another, it's a poor prognostic marker. It just lets you know that patient's in trouble. So the other thing is hyponatremia. Now that lady that I was telling you about when I went to see her, and here's another rule, if you go to do the home visit and they're just wearing a slip, things are not good. You're like, okay, the door's open and my patient's just wearing a slip and she's sitting in the chair short of breath. This is not, there's nothing good about this. So didn't feel good enough to get dressed, a little batty, and I sent her into the I sent her actually into the unit, and her sodium level, 124. Well, let me tell you, rule of thumb is if you have a patient who's crazy, all of a sudden, the things that you want to check out are hyponatremia, because that will make them really crazy quickly. And the other thing, do you guys know what the other thing is? Surely somebody knows. Let's see, UTI? Yep, exactly. So those are the 2 things that you have to check. So, so this lady, 124, because she basically, remember, she wasn't taking any of her diuretic or heart failure meds, so she's basically got water intoxication. So, and I suspect, we did a B-type natriuretic peptide. You guys, we'll talk about that, I think, in a few minutes. Her BNP was 30,000. Okay, that's up. I was like, okay, that's high. So you need to go to the hospital, and we're gonna try to like redirect all this stuff. So, and also the other reason, some patients you'll see that are on really good, like they're on fluid restriction and they're weighing themselves every day, but they're stage D heart failure, and their sodium is chronically 126, 125. That is a different type of patient. These are the patients that actually, because as the cardiac output goes down, their vasopressin is released from the pituitary, and it makes them have sort of that water retention, water intoxication. So that's a different reason. So when I have my stage D guy that's totally adherent to everything and his sodium's really low, it's a marker for really bad heart failure. That lets me know I need to start thinking about hospice and palliative care for this person. The other one, I either want to, you know, I didn't talk about this, the guys that come in with the big gulps, and they're like on the salt lick at home, and then they you've got them on 200 a day, like 100 twice a day of torsemide. Those patients, that's easily remedied. You just have to educate them about, look, your sodium's low, it might make you confused. Nobody likes to be confused. And so here's how we're gonna deal with it. The reason it's so low is because I've got you on such a high dose of diuretics to get rid of the salt that you're eating. And you're peeing out salt, and that doesn't mean you need to eat salt, it means I need to decrease your diuretic, and you need to be really good with this fluid restriction. So that's a different animal, okay? Does that make sense to everybody? Sorta. So a little bit about self-care. I'm a true believer in self-care. The thing is, you're going to try to take your patient from a novice to an expert, right? You want this patient to be an expert. Now, truth be told, let me tell you, this is where HFpEF lives. Inconsistent. I don't know what the answer is for that, but I'm constantly intrigued by it. I don't know. I feel like certainly we're going to figure it out. These patients are so inconsistent. They will wear their BiPAP like maybe 10 days, and then one day they just decide not to wear it, and that's it. And so it's all about getting that patient, educating them, trying to push them back and, look, I need you to be an expert. And that's what I tell my patients, I need you to be the expert. The experts live longer and they have less problems. They have better quality of life. And that's why you want to do that. So this is, many of the studies have looked at this, and they show that you can increase your outcomes by 39 to 56%. So just by having your patient become more engaged, it doesn't mean they would be good with self-management. Like maybe I don't want the patient to be able to take their own diuretic when they're up on their weight, but I want them to consult me. I want that patient to understand that they need to pick up the phone and call me. How many of you guys in clinic have seen that patient that's up 20 pounds with not one phone call? Anybody? I'm guessing a few. So here's the deal. It all goes in with this whole thought process of, I don't want to call Jayne, she's going to yell at me, blah 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 blah. They're going to tell me about my diet, and then it gets really big, and then they don't want to call anybody, and then they don't want to take their diuretics because they're so short of breath they can't make it to the bathroom. So needless to say, this is not a good path to be on, and it doesn't work for the patient. They will end up coming in to the hospital and having to be decongested. I like to keep it super basic with my patients. I feel like we use terminology way too often that they don't understand. That's why I like to actually just give them one symptom to watch for. For you, when you stack that pillow on your bed, you call me. It's a sign for you that you have fluid. So just keep it simple. And this is, what we say to them and what they hear. So why does it matter, that early recognition of weight or the change in the symptoms? By the time my patient has that sort of epiphany, they're already probably up a few pounds. Like I'm already losing the battle. When they call me and they say, Jayne, I'm more short of breath, I probably should have known about it 2 weeks before. They've probably been having higher pulmonary artery pressures. So it just means I really need to move on that when the patient finally calls. Now this, I love this picture. Can anybody tell me what's wrong with that picture? So I had this guy in Newburgh. He was a VAD patient. And he kept having all these swings in his weights, and you'd call him, he'd be up 5 pounds, down 10 pounds. I was like, something is going on. So I go to his house in Newburgh, and sure enough, he's got a Barbie scale. I'm like, oh my God. And it actually had the pink fluff on it, it really was a Barbie scale. And so I said to him, because this guy's got size 13 diabetic shoes on, right? And I said to him, show me how you weigh, which was really scary. And after I said it, I was like, I just need to get out of here. So he steps on it, and it's got, of course, it's the needle. And you can lean either way, and it, tells you something different. And he's holding onto the rail like this, and who can see? So I can't tell you enough how important this one basic measurement is. When we give patients scales in the hospital, the scale is out. I want the patient stepping on it. I want them reading it. I want the nurse to verify it. If the patient can't see it, because a lot of our patients can't see it, and they won't tell you, by the way, if they can't see it, I need to have a talking scale. So I have bigger scales. I have bariatric scales for patients. I have patients or scales that talk to patients. Then you have to make sure they can hear, because that's another thing I've been down. So it's really important, just the basics to cover with these folks, because you'll get a lot of bang for your buck. Up 3 pounds, down 3 pounds is what they say in one day, up or down 5 pounds in 1 week. Now for the advanced heart failure patients, we say up or down 2 pounds. And again, we talked about amyloid a little while ago. It's a different type of heart failure. So those folks, you just have to fine tune it per patient. They really should call you for their symptoms. If they start having any heart failure symptoms, you want them to call you. The fundamental, you've got to do the daily weights. You want the patient when they come in. Have you guys seen the zone tools? I think you have one in there, correct? When they come in, you want them with that. I don't care if they write it on a piece of toilet paper. You want them writing that weight down every single day. And the reason that you want them to write it down is because when you take care of heart failure, you're looking at trends. So if I see a patient and I only have one set of data, I don't really know what to think of it, right? But if I see a patient and I see this calendar and I see that they've lost 20 pounds in the last month or in the last week, it's going to change how I take care of that patient. Sort of like an INR, you just don't want to look at one value. The other thing is the low sodium diet. You want to use the least amount of salt possible, because the way that we combat that is we give the patient more diuretics. Diuretics will not make your patient live longer. In fact, it'll activate the renin, angiotensin, aldosterone system. It is a necessary evil. However, I don't want that patient eating ham and me having to give them tons of diuretics and hurting their kidneys because of it. Does that make sense for everybody? And then make sure that they have a good system for their meds. Okay, a big bag filled with medications is not a good system. If they are on 4 times a day meds and they don't have a pill set, you know, a pill box that is 4 times a day, that's probably not going to work. So look at those basic things, because that's where you get into problems. And patients get really creative on this. Yeah.
Do you give your patients those skills?
We try to teach them in the hospital about that. They go to something called Heart Failure University, and we have a pharmacist that talks to them about that. We send them home with pill boxes.
But the scales, I mean, our CHF nurse case management program, like, we have to get scales from our volunteers have a grant.
Uh-huh.
But finding ones that have the bells and whistles like that, our patients aren't affording them.
So we do give patients scales, and actually I was just at the Northwest Heart Failure Consortium yesterday, and we did a survey for area hospitals, and 10 out of 12 of the hospitals did provide scales for their patients. So, and believe it or not, those bariatric, the talking ones, are cheaper than the healthometer that I give to my patients. They're $100 each, and I can order the bariatric ones, the talking scales that have bigger bases, and it goes to $550, I think. Those scales are like $40 on Amazon, and I'm like, are you kidding me? But I have to order a healthometer for the other ones. So I don't know if that answers your question. And I think CareOregon used to give scales to a lot of patients, and I don't know, I'll let you address that, Paul, as far as, I'm not sure what the process is.
I'll have to double check, but that's my understanding that we've done that in the past.
Yeah.
So I'll make sure that's still current. And
So if you have a
update that.
patient that needs a scale, you got to advocate for that patient and just find a way, because it's like having a diabetic patient without a glucometer. Like it's something they have to have, right? So then what about fluid restriction? We have all patients in fluid restriction when they're in the hospital. They don't need to be on fluid restriction when they're at home, as long as they're not guzzling water. Fluid restriction in the guidelines is only for stage D. Now, why do I put my patients on fluid restriction in the hospital? Is because I'm trying to decrease the length of stay. So if you come into the hospital and you're guzzling water, and then I'm like on day 6 because you're drinking water, I'm like, no, you can like not drink fluids right now. So I'm trying to get rid of this stuff. And so that's why you see a lot of these patients on fluid restriction. And sometimes I really like to check those patients within a week of discharge, because sometimes patients get the message while they're in the hospital, even though we've been telling them for like 5 years. And then all of a sudden they get the message and they go home and they think, well, 2,000 is good. I'm going to do better, and I'm only going to have 1,000 cc's. And they can really get into trouble with their kidneys pretty quickly that way. They can get dehydrated. So that's why the plus or minus 3 pounds, because you want to make sure the recipe that we put them on in the hospital is the right recipe, and many times it needs to be adjusted. This is the zone tool. We're going to actually add a thing to ours where green, yellow, and red. We're going to put the patient's green, yellow, and red. We decided to add that, but it's going to take, of course, you know, OHSU is going to take like 6 months before somebody can get to that. So just make sure you teach your patient what their zones are, and they need to know when to call. So when I see a patient in clinic and their weight's up 10 pounds and they haven't called, then I go, okay, so let's talk about this. Like, do you think you should have called here? And they're like, well, I felt so, and well, let's look at this. Like, maybe you should have, because look what happened. You just kept going up. So it's just another teaching moment for those patients. And you want the patient checking the box, as this comes in handy, especially with the amyloids, because their weight might be up 1 or 2 pounds, and they could have dramatically different days. This also lets me know when I see the patient, if they're living in yellow zone, which they were supposed to call me about anyways. If they're living in yellow zone, I know that that patient has shifted to the right of that curve. And I know that I'm not doing a good job of decreasing my patient's symptom burden, because that's what I'm supposed to do. All right, and so remember, weights, observation, education, and symptoms. And back to Mrs. J quickly. After the hospital discharge, she's lost 20 pounds. She feels really good. She is stage C, New York Heart Class 3. So I moved her back, right? Well, they moved her back. So what am I going to do with her now?
Treat the hypertension. Stay in touch.
Okay. First, I want to go back to my guideline-directed medical therapy. I want to make sure she's on target doses or on the highest dose she can tolerate of those meds we talked about. ACE inhibitor, beta blocker. The other thing I want to do is, she got there somehow from something that occurred, correct? I want to go circle back and figure out what that was and try to make sure it doesn't happen again. So I want to talk to her about, it's a good education moment of, okay, so we've reset the clock. Let's figure out how we're going to keep you out of there. So does that make sense to everybody? And then, so I want to control her symptoms, teach her, educate her, prevent hospitalizations, and I want to optimize the meds. I'm always looking at these folks with HFrEF thinking, can I go up on something? Always looking at that. So if their blood pressure is 120, 130, I want to go up on something. As long as, like if they're stable, I want to go up on something. Okay, and I think that's it, correct?
So you don't want us to ask questions right now?
We should have a little time at the end. We're running just a little bit behind. So
I
what I would
asked
do
you.
is just dog ear that, it's all my fault. But please give Jayne a big round of
Thank you.
applause.
Thank you.